For the second talk, I'm going to be standing in for Nick Willett from the University of Oregon, who was unable to make the trip due to illness. Nick is an associate professor in the Knight campus, and along with Mike Hahn, he is co-director of the Human Performance Alliance at Oregon. And so continuing in this theme of cartilage and joints, we know that joint injuries such as ACL ruptures are extremely common. And they often induce degeneration of the joint, even after surgical repair. And that's a condition called post-traumatic osteoarthritis. There's many different forms of arthritis, and this is one particular form of that follows along trauma, in some cases many, many years later. For athletes, the return to play is very long, and they often cannot return completely to their peak function. And even if they do, they often have a risk of re-injury, as well as development of post-traumatic osteoarthritis for a long time after the injury. Unfortunately, even though there are some treatments to help with pain and management of symptoms for osteoarthritis, the options to prevent or slow down PTOA are very limited. In fact, there are no FDA-approved disease-modifying therapies on the market. There are, though, opportunities potentially for regenerative therapies such as mesenchymal-derived stem cells, but unfortunately, there's been a lot of variability in the results. And so to date, there is no defined efficacy for MSCs in treating post-traumatic osteoarthritis. So there are a lot of questions that come up because in some patients it does seem to work, in other patients it doesn't, say 50-50 amount of the time. So some questions are, what are these cells and what are they doing in the joint? What are the potency of these cells? And this is a really important topic that's come up recently, recognizing that MSCs, even with an individual person, can come from different parts of the body. Basically, wherever you have vascularized tissues, you can derive MSCs. And they're different from the different sites, but certainly between people, they're very different. What is the reliability and consistency of these cells? And can rehabilitation and post-op protocols enhance the efficacy? Really, this idea of regenerative rehabilitation, can you synergize rehab and regenerative medicine? So one thing that we find, and almost everybody, if you look in the literature, finds when you implant these types of cells into joints, they don't live very long. They die very quickly, and so they're cleared from the joints. So here's showing a study by Nick's lab, by Jay McKinney, where they tried to encapsulate the cells as a way to protect them temporarily. And you can see that it had a little bit of an effect, but basically all the cells were gone by 5 days or so. And yet, even with that short duration, there was some therapeutic benefit of the cells. This is a histology on the left, and then a plot showing the articular surface roughness with the encapsulation had a significant effect in the joint, and there was also a decrease in the cartilage surface fibrillation and lesions. So in answer to the first question, what are these cells doing? They're mostly dying, but they're also releasing paracrine effects that can have some positive effects in certain conditions. So what are the potency of these cells? And one of the things that Nick and other groups have noticed is that there's a lot of heterogeneity in the hMSCs, and if you're thinking about paracrine effects, you ought to be interested in what is the secretome, what are these cells producing effectively as drug delivery vehicles, rather than cells that you're putting in and are actually doing, as Chuck showed, rebuilding tissue. And so one of the things that Nick's lab has done is looked at different types of donors, and in this case, he looked at 4 different donors from relatively young ages from 2 different sources, and then characterized what they did in this model. And the model basically that he's using is a rat model of PTOA in which the meniscus is transected, it creates an unstable joint, and the animal develops osteoarthritis within a few weeks. So what they found was something that looked very similar to what's seen clinically. Half the donors had a therapeutic effect and half the donors had no effect. You can see donors 2.3 and 2.4 had a very nice effect on cartilage volume and cartilage lesion volume, whereas 2.1 and 2.2 appeared to have less or no therapeutic effect. And in fact, one of the donors, 2.1, I think it is, actually had a worse effect on osteophytes, which are sort of the bone spurs that occur on the sides of the joints following trauma. So 2.3 and 2.3 were more therapeutic, 2.1 and 2.2 were less therapeutic. To begin to try to understand that, Nick's lab looked at a simulated environment in vitro when they took each of the donors and subjected them to IL-1 beta to cause inflammatory responses. And then they looked at the different factors that were produced by those different donors and found that they were very different among the 4 different donors. And you can see that in the donors that were, you can see differences between 2.1, 2.2, and 2.3 and 2.4, and the more therapeutic donors being on the top. And if you look at this, the less therapeutic donors on the bottom had an increase in the secretion of a larger number of cytokines, whereas the more therapeutic donors on the top were higher for a few factors such as PDGF, GMCF, GRO, and IL-4. And so what Nick has done with this now is started to develop a machine learning platform which combines that secretome, if you will, intracellular signaling molecules and RNA-seq, and began training a machine learning algorithm to predict which donors would be therapeutic and which would be not. And he's expanding this from just the 4 donors that were analyzed previously to now 20 different donors. And he's also beginning to look at, is it possible to take a non-therapeutic donor and turn them into a more therapeutic donor by treating them in vitro before implanting the cells? And so here they're looking at trying to turn these less therapeutic donors into more therapeutic donors. And here you can see on the bottom is the, going backwards. Yeah. All right, how do I go backwards? There we go. Sorry. Dealing with another person's animation is fun. All right, so on the bottom are the less therapeutic donors, which are control treated, so they didn't have any treatment. And if you now look at the treatment, that signaling secretome is now looking much more similar to the therapeutic donors. And so if you look at the factors that were upregulated in the more therapeutic donors, the treatment upregulated that in these less therapeutic donors. And on the right side, the factors that were originally upregulated are now downregulated. And this is looking at a combination of different small molecules inhibitors that seem to be a promising therapeutic to reprogram these. So what is the potency of the cells? They're basically sensors and responders to the local mechanical environment. How can we predict the reliability? Developing predictive multivariate models to basically identify what are sort of the critical quality attributes for therapeutic donors. And potentially, can we shift that secretome by pre-treating the donors? So these are all, I think, would be extremely useful in terms of identifying which cells are actually going to be therapeutic and perhaps take that response rate from something like 40 or 50% up to 60 or 70%, which would be really transformative. And then Nick's lab also is now looking at the interaction between how does the subsequent rehab protocol affect the success of those MSCs. And so we have developed what we call our CrossFit gym upstairs in the night campus. And so there are ongoing studies now looking at MSC therapies, treatments into the joints, and then combining that with various levels of rehabilitation to see if we can find synergistic levels between them. So, and this is just showing a little bit of the combined effects, some early results from this, and you can see in terms of the cartilage swelling, exercise can have a very therapeutic effect. The MMT is the baseline meniscal transection where you have a large amount of swelling. The hMSCs have some effect as well, and the combined also works reasonably well. In terms of osteophyte formation, the MSCs actually work better than exercise. And then in terms of subchondral bone thickening, the combined treatment had the best effect in terms of providing a consistent reduction in subchondral bone thickening. So some questions that we're trying to answer then are, what are these cells? What are they doing? They have poor viability. Perhaps strategies to enhance that viability might be effective, and other people are looking at that. But really leaning into the fact that their mechanism effect is through paracrine signaling is what Nick is really doing, and really trying to identify what are these critical quality attributes that define what are therapeutic MSCs. and then combining that with the rehabilitation protocols to look at how we can synergize those effects. So I'll stop there and just want to acknowledge Nick's lab. Hopefully I didn't completely screw up his results. And I'm sure his students will report back to him how I did. And thank you very much for your attention.